In the latest version of the ESMO clinical guidelines, the treatment intent is regarded as one of the most important drivers for the choice of the first-line treatment for metastatic colorectal cancer patients. In particular, ESMO guidelines divide the treatment intent into cytoreduction, when we want to pursue early and deep response in order to bring our patients to the secondary resection of their metastatic lesions, or when a response is rapidly needed as an urgent need for our patient, and on the other side, disease stabilization as the objective of our treatment in clearly unresectable and asymptomatic patients. The Gruppo Oncologico del Nord-Ovest, GONO, has conducted in the last years different trials, including the use of the combination treatment FOLFOXIRI plus the anti-angiogenic bevacizumab. We wanted to pool data from these trials in order to describe the outcome of patients with liver-limited disease who were included in these trials. In fact, cytoreduction is a primary need, a primary objective, especially for patients with liver-limited disease, when the secondary resection is a pushable aim of our treatment, and therefore we need to pursue cure as the final objective of our treatment for these patients. We included in this analysis 235 patients previously included in the phase 2 single-arm FOIB trial, in the phase 3 randomized TRIBE trial, and in the phase 2 randomized MOMA trial, or in which FOLFOXIRI plus bevacizumab was the induction regimen for all of these patients. Based on our results, FOLFOXIRI plus bevacizumab allows to convert to secondary resection of metastatic lesions the 37% of initially unresectable patients with liver-limited disease. These patients were clearly initially unresectable and displayed quite poor prognostic factors at baseline. In particular, the 90% of them had synchronous disease at the time of diagnosis, the 80% of them had a bilobal involvement of the liver, and in more than 60% of cases there were more than 4 metastases at the time of diagnosis. So these data are hardly comparable with those from other trials, including patients selected with a conversion intent, with a secondary resection purpose, because these patients had a clearly initially unresectable and liver-limited disease, but were not included in this trial with the aim of pursue a secondary resection, differently from other trials in the liver-limited setting, such as the SELIM or the Olivia trials. So I think that there are 3 main crucial messages from this paper. The first one is the role of FOLFOXIRI plus bevacizumab as a valuable option when conversion is an objective of the treatment, and the importance of adopting from the very first steps of the disease history of patients with liver-limited disease with an objective of secondary resection, a regimen that allows to achieve early, deep response and tumor shrinkage. The second message is the importance of converting to resection these patients and the opportunity to give them a long life expectation thanks to the good long-term outcome results that are observed with this kind of regimen. And the third point is a suggestion coming from these data, because in resected patients, no impact of traditional poor prognostic factors was observed. I mean, patients resected following FOLFOXIRI plus bevacizumab had no differences in their long-term outcome based on clinical characteristics, including Norlinger or Fong scores, clinical scores, or based on their molecular status. While in other series it was suggested that BRAF mutant patients had a very short time to relapse following radical resection of liver metastasis, this is not confirmed in this series. it looks like that FOLFOXIRI plus bevacizumab is able to counteract the intrinsic biologic aggressiveness of BRAF mutant tumors and allow patients resected following FOLFOXIRI plus bevacizumab to achieve considerable long-term results.